So we're going to talk about a way of trying to reward quality medical care through a strategy called paying for performance, often abbreviated P4P. Um, and to understand this, we're going to go ahead and start with a patient. A man who wakes up one morning with pretty severe chest pain. He's worried he's having a heart attack. So he calls an ambulance, maybe goes to the emergency room where he gets some treatment. And oftentimes people believe that the ideal treatment when you get there is, you need to get some aspirin right away. It's often abbreviated as ASA. Another medication called a beta blocker. You'll be evaluated by doctors and cardiologists, and they might say that, yep, you're having a heart attack. We need to go ahead and give you emergency angioplasty. So you might go into a hospital where you see a cardiologist and have an angioplasty, perhaps with a stent or something like that put in. Usually that has to happen in a certain period of time to make sure your heart survives that. And then you might get admitted into an intensive care unit after that and need to get certain treatment there. And hopefully they would also say, well, hey, this person, in addition to improving from the acute heart attack, should stop their smoking if they're smokers. And they give a bunch of other advice and care and ultimately try to go ahead and get our patient home in good condition. So that's sort of the way that medical care would progress here. And traditionally, as we've talked about in some of our other tutorials, this was also paid for. And in the past, when Medicare or other people paid for the treatment in the emergency room, and hospital and ICU all together, there was really no thought to quality. Didn't matter whether you gave the right medicines or not. Didn't matter whether your patient did well or not. You still just got paid the same amount. And that was sort of the traditional fee for service without real accountability. And so pay for performance tries to take into account whether or not the hospitals and health system are actually doing a good job. In other words, did they do the evidence-based kinds of care? Did they give that aspirin when they got to the emergency room and give the beta blocker? Do that angioplasty within 2 hours? Make sure that they talk to you about stopping smoking and so forth. And so pay for performance, this concept is trying to alter payment to be either more or less depending on whether you do the things you're supposed to do. Sounds like a great idea, but the reality, it turns out, has been much more complicated. And this story probably dates back to the best demonstration of pay for performance, which was done in 2003. And this was an experiment, essentially, that was started by Medicare called the Hospital Quality Incentive Demonstration, HQID, done in collaboration with a company called Premier. And what this was essentially a pilot project where people got together and said, for these conditions, then they chose 5 of them: hip and knee replacement, pneumonia, heart attacks, heart failure, and bypass surgery. We're going to create 34 measures of quality. And we're going to sort of, maybe just to talk about heart attack, they did include that aspirin, beta blocker, angioplasty, smoking cessation, and a few other things. Most of these are what we called process measures. In other words, did doctors do the right thing? Now let's put that in parentheses here. And only a few of them were what are called outcome measures. In other words, did patients really survive? But in any event, the theory was that, well, hey, at least we can make the processes better. And if we pay people to do that, that'll be a good idea. And let's talk about how that incentive worked. They'd measure all the hospitals, and those in the top 10% of hospitals that entered into this demonstration could get a 2% bonus on Medicare rates. And if you were in sort of between the 80th and 90th percentile, in other words, the next 10th percentile, you got a 1% bonus from Medicare. So that was the way it was structured. So in other words, a total of the top 20% of the performers would be eligible for 1 to 2% bonuses on their Medicare rates. So that was sort of the way the incentive structure worked, and years later, people went back and analyzed this data to say, did it really work? Hey, did quality get better? And the data is interestingly mixed. I'm just going to go ahead and erase a little bit here and talk about what that data actually showed. So, it turned out that hospitals generally did improve their quality of care, meaning their adherence to these parameters a little bit. So whereas they might have been maybe like 80% adherence for some of these processes, after several years they were up, to maybe 90-ish% or so. And this is over several years of the program. So yes, some of the processes of care were a little bit better. Still not perfect compliance, but a little bit better. One of the things that was interesting, though, was that in the background for hospitals that weren't really part of the pay for performance, they also improved over time. So it looked like the improvement between that could be attributable to the actual quality program or the sort of intervention was actually fairly small. And there's a lot of reasons that might have been. In any event, what was the outcome on stuff that people actually cared about as well? And this is where things got really interesting. So, yes, people sort of gave aspirin, maybe they gave beta blockers and focused on all that stuff. What about the stuff people really cared about? In other words, did adhering to these process measures really lead to better care in these areas? And there the data was particularly disappointing for advocates of pay for performance. It turned out that on meaningful measures, such as did they get out of the hospital and stay out for more than 30 days? Did they live longer? And this was at follow-up at even 3 to 6 years afterwards. There did not appear to be impact. And they looked specifically not just at all hospitalizations and discharges, but those that would have been affected by pay for performance. People who had actually had heart attacks, had hip and knee replacements, had heart failure. And so it appeared as though the traditional pay for performance started by Medicare did not seem to really make a difference in those types of outcomes. There's many reasons that people have felt this did not have an impact. I'm going to go ahead and review some of them. So, probably one of the biggest explanations that's been given is that people kind of didn't really identify what really mattered. So, part of maybe the first reason was that the measures were not good. In other words, they didn't really capture what really mattered to these patients to help them live longer. It's much more complicated to make sure that people survive from these problems than what those 34 things looked at. The second is that trying to motivate doctors to do a good job in this way wasn't really done very well. And that perhaps there needs to be broader changes, sort of more cooperation, and perhaps just focusing on this list of things people need to do really misses the key areas of importance. And this was particularly dramatic because in the UK, when they started this pay for performance model, they actually did show positive change. And that was because some people believe it wasn't just a mandate. They actually went out. They really taught doctors how to cooperate. They didn't just sort of have them fill out checklists, but there was sort of a broad-based engagement strategy. That may be one reason why pay for performance wasn't as effective in this model in the U.S. The third reason is that the incentives may have been too small. And, even though the hospitals really cared about these incentives, maybe they didn't really drive the broad-based change to a large enough degree. And again, the UK experience is instructive. There, the incentives weren't 2%, but rather 4%. So the incentives were 2 times as much in the studies there that did show an impact. In the US, however, that has not yet happened. And so I think that most people can agree that pay for performance, at least at the hospital level, has not yet shown itself to be extremely effective in improving outcomes. Be that as it may, pay for performance is probably here to stay at the hospital level, largely through the Affordable Care Act, or Obamacare, which was passed in 2010. The Affordable Care Act expands pay for performance into a program called Value-Based Purchasing. So value-based purchasing will now impact pretty much all of Medicare. And it turns out that almost over 99% of hospitals will now participate in this program. And there will be these measures. And so this is pretty much here to stay. And the key thing over time is going to be whether adequate measures will be developed that many physicians, health systems, and patients can agree are going to be beneficial in the long term. So stay tuned about that. So we've talked about pay for performance at a hospital level. It turns out that those types of pay for performance measures used by Medicare in the past through that demonstration don't really apply to most people, right? That was just a small list of diagnoses, those 5 things. What about all the people who get care in their doctor's offices? That actually is done through a different program which started in 2007. That was called the Physician Quality Reporting System. Today it's called the Physician Quality Reporting Initiative. Whoops, PQRI, sorry. And this is very different. Instead of hospital-based payments, these are payments that go directly to doctors. And here there's almost 200 different measures that have been proposed for all kinds of things that you see in an office. You know, whether you do a good job taking care of a back pain or knee pain or headaches or high blood pressure. And this is an extremely complicated system. And here doctors in their offices, just as hospitals could stand to make more money, could stand to make a few percent bonus from Medicare if they meet certain targets. Interestingly, however, hospitals, a few percent is a big deal for them because their margins are so small. A few percent for doctors is not really a big incentive. They make much higher margins, so a few percent is really not really thought to be very much. Actually, interestingly, only 30% of doctors have chosen to participate in this program. That means the majority of doctors have said, no thank you, I don't want to be part of that. Measuring all that stuff is just too much hassle. And many people also believe here that these measures, at least doctors' opinions, that they are not very meaningful. There's been several academic articles that have been written sort of looking at how doctors feel about these measures. Just as in hospitals, they don't appear to have driven serious long-term improvement in outcomes. Many physicians in practice find that these 200 measures that have been proposed for all kinds of outpatient issues are not meaningful. And maybe that's another reason that only 30% have chosen to participate. However, as the Affordable Care Act has expanded pay for performance through value-based purchasing, there is also now legislation being proposed that would take physician-based payments here and tie them to long-term Medicare payments as well. And this is through proposed legislation for fixing something called the sustainable growth rate. I won't get into details around that, but in other words, it is possible that this too may become standard. But again, we'll have to stay tuned to see if that happens.